About JAK inhibition in rheumatoid arthritis, about clinical significance of JAK selectivity.
Thank you very much, and it's very kind of you to invite me to give this talk in this conference, and I'm sorry I can't be there in person, but I hope to be able to convey all the message and answer all your questions during my talk. So if you would excuse me for one moment, I just need to make sure that I can get used to the technology. I need to go back on my slide. I want to see where my controls are. Can I go back to the beginning? Okay, thank you. So the topic of my talk is about JAK inhibitors in rheumatoid arthritis. We have a number of JAK inhibitors recently approved for the treatment of rheumatoid arthritis. They are said to have different JAK isoform selectivity, and one of the most important questions for many clinicians is whether these JAK selectivity leads to clinical differences among the JAK inhibitors, which is going to be the topic of what I will try to address during my talk today. Next slide, please. So these are my disclosures. Next slide. So just started from the beginning. We know that in many chronic inflammatory diseases, and that includes rheumatoid arthritis, the disease process is driven by cytokines, which are important messengers allowing immune cells to communicate with one another, and also allows immune cells to communicate to the local tissue, which generate the disease features and phenotypes. And be it from the beginning of the disease on the left-hand side of this slide to the established disease, cytokines are involved, and we know that there are many, many cytokines involved in this process. Next slide. Importantly, what we know from these different processes, different cytokines are involved, and I'm using this slide to illustrate that different cytokines are involved in the recruitment of inflammatory cells into the joint, from how these cells are retained and maintained in the inflammatory environment, to how then these cells become organized and develop and maintain inflammation, and last but not least, in causing inflammation and joint damage. It is now pretty clear that in fact different cell types and different cytokines are involved at different stages of this biologic process. So you will be familiar from the last talk that we have many monoclonal antibodies approved for the treatment of rheumatoid arthritis over the last 20 years. And one of the heterogeneity in response probably results from the fact that monoclonal antibody tends to target a single cytokine. So with only targeting a single cytokine, it is unlikely that we can impact on every single stages of the disease, and that may be one reason why we are seeing heterogeneity in clinical response. Next slide, please. So there's always been the aspiration with the success of anti-cytokine therapy that we may move from using expensive biologic molecule to more readily available oral treatment for chronic inflammatory diseases. And one way of achieving that goal would be to target the intracellular signaling pathways. This slide shows that in fact different cell surface molecules, and that include cytokines, use different intracellular signaling pathways. And therefore it may be possible to inhibit these pathways. If we know which cytokines are involved, then we may target the specific pathway. So obviously, what we are going to focus on is on the left-hand side of this slide, the JAK-STAT pathway. And they are chosen because really the JAK-STAT pathways are involved in the signal transduction of many, many inflammatory cytokines that I will try to illustrate during this talk. Next slide, please. So the Janus kinase system, in fact, when it was first named, was called just another kinase. But it was renamed after the Roman god Janus because of the following reasons. The Janus kinase are associated with the cytoplasmic tail of cytokine receptors. The Janus kinase exists in 4 isoforms: JAK1, JAK2, JAK3, and TYK2. And as I will illustrate in the next few slides, that the Janus kinase always act in pairs. And because they act in pairs, it was renamed after the Roman god Janus, because the Roman god Janus is always depicted as faces facing opposite directions. Next slide. So this little animation illustrates for you how the Janus kinase system works. When the cytokine docks onto cytokine receptor on the surface of the cell, it brings together a couple of cytokine receptors together. And by bringing them together, it also brings together a pair of the Janus kinase. Next click, please. So one Janus kinase will phosphorylate the opposite Janus kinase and vice versa. The consequence of this is that it exposes active phosphate molecules on the cytoplasmic tail of the cytokine receptor, and this allows STAT molecule, which is in the cytoplasm, to dock onto it. Next click, please. So the phosphorylated STAT molecule is able to translocate from the cytoplasm to the nucleus, which result in gene transcription. Next slide. So one strategy to inhibit the JAK-STAT pathway is to block the phosphorylation domain of the Janus kinase. Next click, please. By blocking the phosphorylation domains, it stops the Janus kinase to signal, so it inhibits the subsequent pathways. Next slide, please. Next slide. I mentioned before that, in fact, the JAK-STAT pathway is involved in the signal transduction of many cytokine families, which is well illustrated by this slide. So you can see, ranging from the common gamma chain cytokines, type 1 and type 2 interferon, the IL-6 family of cytokines, IL-12 and 23, as well as the haemopoietic cytokines, all utilize the JAK-STAT pathways to cause signal transduction. Importantly, you will notice on this slide is that for each of the cytokine family, they tend to use different JAK isoform pairs, which are depicted with different colors. And for most cytokine family, they utilize JAK isoform as heterodimers. That is, the JAK isoform on one side of the cytoplasmic tail is different from the other JAK isoforms. And it is the using of the different JAK isoform pairs that leads to the phosphorylation of different STAT molecule. Hence, different cytokine family mediate different biologic function. You will notice too that in fact there is an exception to the rule of JAK isoform heterodimer signal transduction, which is on the right-hand side of this slide. So you can see that the haemopoietic cytokines IL-12, 23, erythropoietin, GM-CSF, and thrombopoietins uses JAK2 homodimers to cause signal transduction. So what it means is that if you want to inhibit these cytokines, you must inhibit JAK2. Now, because the JAK isoform act as a pair, you don't need to inhibit both sides of the cytokine receptor. You only need to inhibit one of the pairs to have an inhibitory effect on the downstream pathway. Next slide. The other thing that I want to highlight, which differentiate between JAK-STAT inhibition versus inhibition of cytokine by monoclonal antibody, is that the JAK-STAT pathway are very important not only in immunity and protection against infection. They're also important in maintaining many physiological function, especially the hemopoietic function. What that meant is that the aim of JAK-STAT inhibition is unlike inhibiting cytokine using a monoclonal antibody. In the case of anti-cytokine monoclonal antibody, we aim to reduce the function of the cytokine by 90%. And we know that for many monoclonal antibodies against cytokines, we need to achieve free monoclonal antibody level in the circulation in order to suppress inflammation. For JAK-STAT inhibition, what we are doing is turning down the inflammatory activities of many pro-inflammatory cytokines without completely blocking them. So as a result, we are tuning down the inflammation response, but we don't really completely block any one of the JAK isoforms in clinical practice. Next slide, please. Now, I'm going to explain how JAK selectivity is measured and just put in a statement before why we need to interpret JAK selectivity with caution. So on the left-hand side of this slide, I've already mentioned that for all the current JAK inhibitors, they all target the active kinase domain where phosphorylation occurs. And the selectivity is based on the shape of this pocket, and that allows a compound to be selected based on the relative ability and potency of the inhibitors against the different isoforms. The way that JAK selectivity is measured is based on taking usually blood samples from a healthy donor. You add in the JAK inhibitor, and you read out the production of cytokine or phosphostat molecule to address the issue is how much of the inhibitor I need to add in order to reduce either the cytokine or phosphostat by 50%. By doing that, you can work out what we call the IC50, that is the concentration of the drug required to reduce the cytokine or phosphostat by 50%. So the lower the number or the lower the IC50 is, the more potent the inhibition is. Next slide, please. So one word of caution, though, when we interpret this result, is to remember that, in fact, whilst the JAK-STAT molecule is ubiquitously expressed, and that by that I mean it is expressed by every single cell in the body, the JAK-free isoform is only expressed by the immune cells and the hemopoietic cells. It's not expressed by any other cell type. And this unique expression means that the JAK-free inhibition will only have an effect on hemopoietic cells, but not other body tissue. Next slide, please. Now, I'm going to use this slide to explain what the in vitro experiment I explained earlier, that led to the claims of JAK selectivity. So, for example, we can look at Tofacitinib, which is said to be a JAK1/3 selective inhibitor. And if you examine the IC50, you will see that the IC50 is lowest for JAK1 at 15, followed by JAK3 at 55, then JAK2 at 77, and 489 for TYK2. So Tofacitinib is most potent for JAK1. For Baricitinib is said to be a JAK1/2 selective inhibitor because for JAK1 and JAK2, the IC50 is fairly close together at 4 and 6.6. And if you compare this number with the IC50 of TYK2 and JAK3, these numbers are a lot lower. And the same is true for compounds such as upadacitinib and filgotinib, which is said to be JAK1 selective because the IC50 for JAK1 is much lower than for the other JAK isoforms. Now, important to note is that these different molecules have different potency anyway, so the IC50s are dramatically different amongst the different JAK inhibitors, okay? And the second thing we need to note is that whilst we said that Tofacitinib is most potent for JAK1, followed by JAK3, followed by JAK2, the IC50 between JAK3 and JAK2 are relatively close together. And what that means is that I can, at low doses, Tofacitinib may well be selective for JAK1 and for JAK3, but if I were to increase the dose, what I will start to observe is inhibition of JAK1, JAK2, and JAK3 altogether. And the same principle would apply to other JAK inhibitors. Now, one thing we know for rheumatoid arthritis, given that in Europe, Tofacitinib, Baricitinib, and upadacitinib are all approved for the treatment of rheumatoid arthritis, and all of them inhibit JAK1, we can be fairly confident to say that JAK1 is a good therapeutic target in rheumatoid arthritis. So if we were to develop a new JAK inhibitor, the first thing we want to look at is how potent it is in inhibiting JAK1. If we were to achieve that inhibition on the right-hand side, we can start to look at the relative inhibition of the other JAK isoforms. So actually, if you look at Tofacitinib, the ratio between JAK2 to JAK1 is 5.2, and the ratio between JAK3 and JAK1 is 3.6, which means that the so-called selectivity is very sensitive to changing of the dose. If we were to increase the dose, it's very easy to achieve JAK2 inhibition at high doses. And you can interpret the same level against the other JAK inhibitors. Next slide, please. The other cautionary tale has been illustrated by Ian McInnes in this paper. So when he looked at the inhibition of different cytokines by JAK inhibitors, and in this study, he included Baricitinib, upadacitinib, and Tofacitinib, and look at the expression of different phosphostat molecules as well as cytokines. What he illustrates in this slide is that the inhibition mediated by JAK inhibitors are not 24/7. So on the horizontal axis, the inhibition observed over a 24-hour period, and these horizontal lines are the IC50. So when you are above the IC50, you are achieving significant inhibition. If you are below the IC50, you are starting to lose inhibition. So what this slide all tells us is that the inhibition of cytokines mediated by JAK inhibitors does not always last for 24 hours. In fact, in the majority of the case, it lasts roughly about 12 hours. So it is not, it's also unlike monoclonal antibody. JAK inhibition is not sustained over a 24-hour period. Next slide. So the JAK selectivity has been useful for researchers and for pharmaceutical company in order to think about whether the inhibitor will be useful in treating certain conditions. So I've already mentioned that JAK1 is a good target in rheumatoid arthritis. Now, in rheumatoid arthritis, IL-6 is a proven therapeutic target, and we know that the IL-6 family of cytokines signal through JAK1, JAK2, and TYK2. So it's consistent with the effect of JAK1 inhibition. What we also know, however, is that for the JAK inhibitors, in order to inhibit IL-12 and 23, you need to inhibit JAK2 and TYK2. So not surprisingly, if you only have a JAK1 selective inhibitor, its potential of treating diseases that are mediated by IL-12 and 23 will not be so useful. And so diseases that are known to be mediated by IL-12 and 23 are inflammatory bowel diseases. So for these conditions, you would think that having an inhibitor that only inhibits JAK1 may not be as effective. So these are guides and not absolute indication of selectivity, and definitely not in clinical practice. Next slide. The other caution I want to throw into during this talk is that unlike monoclonal antibody, where the metabolism is the same, because JAK inhibitors are small molecules, they all vary in their way of being metabolized. Some of them are metabolized by the liver, and others are excreted by the kidney. And in fact, because the metabolism are different, and the concentration in the individual patient will be different, and they will be driven by genetics, the BMI of the patient, the formulation of the drug, and also they all have different drug-to-drug interactions. So many factors will influence the level of drug being achieved in the individual patient. So it is hard to translate what we know in vitro to every single patient in clinical practice. So we need to exercise extreme care in taking only in vitro experiment result to say that this is what we will see in clinical practice. Next slide. So I'm going to move on to talk a little bit about the JAK inhibitors in clinical practice. And obviously, one thing that differentiates the JAK inhibitors from our biologic agents is the fact that they are orally available, orally administered treatment, which is very different from a parenteral treatment we have to give for biologic agents. Next slide. We know that many patients prefer oral treatment than parenteral administration. That is definitely a known advantage. Next slide. And this is a meta-analysis conducted by Janus and published earlier this year, looking at the effect of different JAK inhibitors, Tofacitinib, Baricitinib, as well as upadacitinib. And if you look at ACR 20, 50, and 70, they all have overlapping 95% confidence interval. So they are effective. The difference of between them amongst efficacy, if there is a relatively small one from this meta-analysis. Next slide. One thing that differentiates JAK inhibitors with the biologic agents is the association with zoster reactivation. These are data from the German rabbit registry showing that zoster reactivation associated with JAK inhibitors are significantly higher than any of our biologic agents. And the potential explanation of this is that JAK inhibitors inhibit interferon, and interferons are very important in antiviral response. And what we observe here may be related to anti-interferon effect. Next slide. The other question that has generated a lot of interest recently has been venous thrombosis. So many studies have shown that patients with rheumatoid arthritis are at risk of venous thrombosis, and two papers have summarized the potential explanation. On the left is the increase in clotting factors. On the right, increased endothelial activation. Both of them can explain the increased venous thrombosis risk. Next slide. An epidemiological study have shown that patients with rheumatoid arthritis have a 50% increased risk of venous thrombosis compared with non-rheumatoid arthritis patients. Next slide. One thing that has generated a lot of concern since the end of last year has been the European Medicines Agency warning against using high-dose tofacitinib in patients with rheumatoid arthritis, because in an oral surveillance study, when the two doses of tofacitinib, 5 and 10 milligrams, were compared to TNF inhibitors, high-dose tofacitinib at 10 milligrams BID were associated with increased risk of venous thrombosis, particularly PE. So as a consequence of that, patients at high risk of venous thrombosis were advised not to take a JAK inhibitor, and especially with high doses of treatment should not be prescribed in patients with rheumatoid arthritis. Next slide. And there are some real-world data to support that randomized controlled trial result. This is based on the recent presentation at EULAR. looking at the World Health Organization's pharmacovigilance database, and especially in Europe, there is a suggestion that both Tofacitinib and Baricitinib may well have an increased risk of venous thrombosis. Next slide. So I want to talk to the last bit of my slide to look at the argument for and against inhibiting other isoform outside JAK1. There has been this argument that if we have more selective JAK1 inhibition, so something that only targets JAK1, then we can reduce pro-inflammatory cytokine activity mediated by cytokines such as IL-6, but we will reduce some of the side effects associated with JAK2, particularly hematological side effects. Next slide. However, there is an argument that JAK2 is important in GM-CSF signaling, and trials of anti-GM-CSF antibody have shown therapeutic benefits. So you can argue that perhaps the risk of blocking JAK2 may well be balanced by the benefit of additional GM-CSF inhibition. Next slide. And one thing we know about anti-inflammatory treatment, particularly about the effect of IL-6, has been the impact of IL-6 on generating anemia of chronic diseases. Next slide. Which is mediated by the hepcidin molecule produced by the liver. Next slide. And we know that, in fact, if we look at anti-IL-6 treatment, not only we get a very rapid reduction in CRP level, which is shown in gray in this slide, what we also see is a steady increase in hemoglobin level, and that is mapped by reduction in hemoglobin. And that effect is not unique only for IL-6, but also applies to TNF inhibitors. So you can see that with TNF inhibitors on the top panel, both in rheumatoid arthritis and psoriatic arthritis, you get increases in hemoglobin level. Next slide. If we look at Tofacitinib as a relative JAK1 and JAK3 inhibitor, what we notice is that there's a small increase in hemoglobin associated with 5 milligrams of Tofacitinib, and you can see that these changes is slightly higher than the placebo-treated group. Interestingly, in the Tofacitinib 10 milligram group, what you see is that there's a loss of this increase. In fact, the trend is in the opposite direction. There's a less increase in hemoglobin when high doses of Tofacitinib is used, and that reflects the fact that when you switch from 5 milligrams to 10 milligrams, Tofacitinib has switched from a relatively JAK1/3 selective inhibitor to a JAK1/2/3 inhibitor. Now you can see for Baricitinib, the effect of JAK2 inhibition. So you can see that for Baricitinib treatment, be it 2 or 4 milligrams, you get a reduction in mean hemoglobin. And in fact, this reduction was, if anything, higher than the placebo-treated patients. Next slide. And you can induce this change in hemoglobin to infer whether a specific inhibitor has a JAK2 effect. So you can see the change in hemoglobin reported in 2 trials of upadacitinib. You can see that 50 milligrams of upadacitinib is associated with a very small reduction in hemoglobin, but this reduction in hemoglobin perhaps is comparable with the placebo group. But once you go on to 30 milligrams of upadacitinib, it starts to get much greater reduction in hemoglobin. So it shows that when you're using upadacitinib at 30 milligrams, then you're starting to really affect the JAK2 pathway. Now, I won't go into the filgotinib result, in part the way that the change in hemoglobin result was different from other studies, but we want to see more data if you want to assess whether filgotinib have any JAK2 effect in clinical practice. Next slide. So in summary, what I've hoped to show to you is that JAK inhibitors is clinically efficacious and the effect is very similar to biologic DMARDs. The safety profile overall in terms of infections are similar, but there's a specific signal for zoster reactivation, and there appears to be an increased risk of venous thrombosis associated with JAK inhibitors. In choosing treatment, of course, patients would prefer to have an oral treatment than injection, but many patients would accept injection treatment too. Inhibition of JAKs have a complex effect on multiple intercellular cytokine signaling pathway, and we are starting to have hypotheses about the relative importance between inhibiting JAK1 and JAK2. JAK1 is definitely a good therapeutic target in rheumatoid arthritis, but there may well be a balance to be gained in efficacy versus risk when we start to inhibit JAK2. And the magnitude of inhibiting JAK2 may well be ultimately the crucial factor in deciding whether it's good or bad in individual patients. And in clinical trials, I've suggested to you that changes in hemoglobin will be one way of assessing whether something is very JAK1 specific, because if you're starting to see changes or reduction in hemoglobin level, that would suggest that a compound have JAK2 inhibition. Thank you very much for your attention.